Good afternoon, or morning, or good night, or whatever time you're watching this. This is going to be our week 2 lecture, just a quick overview on some of the bullet points and learning objectives that we are expecting you to learn throughout the course of this module. Today, we're going to talk about government oversight, regulatory agencies. We're going to talk about kind of very briefly how laws and regulations are passed. I know you covered that in your foundations class or intro class. And then we'll get a little bit into revenue cycle and budgeting. One of the things that I will lead off with this and make a mental note is if you are getting into the management realm of emergency medical services or fire-based municipal commercial, the two things that I will tell you is number one, master the regulations, understand the statutes and regulations better than the employees of your Office of Emergency Medical Services in whatever state you are working in. And the second thing that I will tell you is get involved in the legislative process, whether there's advisory boards, regional committees, medical advisory councils, paramedic advisory committees. Sit on as many of these meetings as you can so you're in the know, because what you want is most of these committees, advisory boards, panels, boards will have some form of legislative subset that will kind of tell you when a bill is coming. And then if it's something that's important to you, you can either test for and against it. And I never really thought that that was going to be the case. But I will tell you, I did deep dives into the regulatory authority in the state where I live and was able to, masterfully navigate that to benefit the taxpayers that I was sworn to serve and protect. But then moving forward, I was able to actually identify boards and panels that would help the profession long term. And so I see it all the time, and I would just definitely caution or advise you to do that. So first off, let's understand that there's a whole bunch of different government agencies, right? We all know about National Highway Transportation Safety Administration. That comes up with the education standard and the standard of care and the scope of practice. We know that we're going to have DHHS, Department of Health and Human Services, which is going to control the Center for Medicare and Medicaid Services, which we'll discuss a little bit future. Your most localized regulatory is actually going to be your sponsor hospital. So whoever sponsors you, offers your medical oversight, your medical control function for your service is going to be your most localized regulatory authority. And then obviously, most of your licensing, credentialing, and stuff will probably come from the state, whatever your state office is. So we know that we have those different things that are certainly governing the way we operate. So what happens? Like, how do these different state and federal organizations operate, right? Well, again, quick overview of civics, right? There's statute and there's regulations. And statute's ironclad. That's the legislative process that has to be voted by a House of Representatives. It has to be voted by a Senate or whatever your governmental body is in your state. If you live in a Commonwealth, it might be slightly different. Then it has to be signed off by the chief executive, whether that be the governor or the president of the United States. It then becomes statute, whether it's state statute or federal statute. Where the regulations come in is the regulatory phase is usually deferred to by some form of statutory process. So, I live in Connecticut, in the state of Connecticut, where Charter Oak College is. Statute is passed, and then in statute, there is actually a defining process for how to change the regulation. So in our state, the Office of Emergency Medical Services is then going to go ahead and create an updated regulation, and that has a spelled out statutory process to get all the way through the executive branch so they can authorize that. So in a nutshell, statute, legislative branch signed off and implemented by the executive, regulation almost entirely controlled by the executive branch, right? So it's not voted on by legislative process. So the creation of bills, maybe I'll post a video. You should see the video in your hierarchy, but the commercial about I'm just a bill. In a lot of states, it's a one-liner, kind of tells you it's coming. Hey, we're going to adjust the way we do Medicaid reimbursement. Okay, now we're all paying attention. Then the bill actually gets drafted, gets brought to committee. Usually there's public hearing, and then it either gets voted out of committee or voted down in committee. If it gets voted out of committee, it'll go to the floor of that legislative chamber. Then it has to go to the other legislative chamber. They have to agree on it, and then it goes to the executive for signature. It is supposed to be slow. It is supposed to be hard to affect change. That was the way the system was designed. So don't expect anything fast to come out of the legislative process, right? So one of the things that's in the legislative process a lot, especially at the state level, is the reimbursement rates for the revenue cycle. Now, revenue cycle and payer mix on how you make your money is going to be in a commercial setting, how you're going to, arguably live and die in this business. EMS is built in a fee-for-service model, much like the rest of the United States healthcare. Fee-for-service model essentially means Scott Martis gets in his ambulance with his pal Buckaroo Banzai. We go to the call, we perform 911 services at the advanced level. We drive that patient to the hospital. We send an invoice to the patient or their insurance carrier, and we get a fee for that service. No different than if you go see Dr. Strange for a spinal cord injury, and he operates on your spinal cord before he messed up his fingers, of course. And you can suddenly walk again. He's going to charge you an exorbitant fee, which is why he crashed a Lotus on Route 9 in New Jersey. So these are the things that this is the way the fee-for-service model, works, and very common in all of healthcare. And I think what the problem with EMS is, it's one size fit all, right? So you could be a fire department, you could be a paramedic, third service, commercial service, nonprofit, church-based service, Jewish synagogue-based service, and you get the fee-for-service model. Right now, on the fire rescue side, where we start to see a lot of the county systems, we do see some aspects of that in the New England states, in the tri-state area as well. You should be able to or want to offset some of that with taxes. But then people don't understand, well, wait a minute, I have this fee for service model. Why do I have to pay taxes for the, Hotch and Scotch Ambulance Association? Why am I sending them $500,000 when they sent me a bill the time I had chest pain? Because my insurance didn't cover it. And so that is a cycle. We almost put the onus on our EMS system, just like the rest of our public healthcare system, is based on the fact that if you cannot make revenue, you cannot survive. So that's an issue, right? And so we have to look at some of the alternate areas in which we can make some improvements. And arguably, it would come down to people paying for that, right? And how do you do that? And some towns, many communities do that, right? So one of the things that we have to do as a manager is we have to understand the importance of our budget. So it's one thing to go out and master finance, which there's an entire class on finance and EMS. So, we're certainly not going to cover it in a 20-minute lecture and a couple pages of a textbook. But, one of the things that we can cover and we can at least talk about is the importance of a budgeting process, and basing that budget on what is going on in both the regulatory process and what is going on in your community, right? Budgets and revenue cycle is all based on demographic. So when we look at U.S. healthcare, we have multiple types of payers, right? And a payer is who's sending you the check. I did the service, who's sending me the check? So what do? We look at things like government payers, Medicare, which is federal government, which everybody essentially goes on now at 65 years old. Some people younger, depending on their disability status and et cetera. And then we work on Medicaid, which is usually your state. And sometimes it's a subsidy from the Medicaid. So people may have both, but a lot of times they have Medicaid if they're on Social Security, benefits for disability, or they're on welfare, stuff like that. Medicare, if they're federal. Most of this money is going to come from CMS. It's going to come from the federal government. It's going to trickle down through the states. The states do regulate the Medicaid, and CMS, HHS regulates Medicare. And like every other government project, it's if you did your tax return, you know how difficult it must be to navigate the Medicare regulatory environment. And it is very difficult. And I will tell you that if you're going to wind up becoming a manager, the other thing that I would advise you to do is look up the American Ambulance Association and look up their guide to Medicare and Medicaid services, because they will highlight all kinds of regulations, because very, very often they come after ambulance companies and they come after them for fraud. And a lot of times it's not fraud, it's mistake, because it's a code like this and it's just tough to navigate. So that's something that you would want to learn. But when we look at these payer mixes, right, I mean, Medicare and Medicaid nationally make up for almost 60% of all of the payers in EMS. So a government payer, now, newsflash, the government payers do not pay as much as the private payers, the commercial, like your Aetnas, your Blue Crosses, your Cignas, right? So 60%, you're already operating at a loss because unlike the contracts that we would say, right, with a Cigna or a Blue Cross Blue Shield on how much they're going to pay us, the government tells us what they're going to pay. We don't have a choice. They come out and they say, we're going to pay you $236 for a BLS transport with 11 cents per mile. Right? You're like, okay, it's better than zero, right? Whereas Blue Cross may pay you $787 for that same transport with $15 a mile based on the contract. So that's important. So when you're working within your budget, it's very, very important. This creates a circle with itself because if regulatorily they're going to cut CMS services and they're not going to pay, the reimbursements are going to go down, or Medicaid isn't going to have an increase this year, then my budget needs to be planned at 60% of my generalized inflationary revenue is going to be stagnant, zero. So if I have a 60% payer mix, that's government payer, and they're not doing a raise or they're going to decrease it, I need to count that for the next year's budget. So that's why this legislative process is very, very important, because the cost of gas is probably going up, cost of steel, cost of ambulances, all of this other stuff is going to go up, cost of labor, all these things are going to go up. So it becomes a budgetary crisis if you can't find a subsidy from things like grants and other stuff. Now, grants and subsidies and even local taxes, they equate to like 5% of the national payer. 5% of the national payer is made up from grants and then tax subsidies. 5%, right? 60% is the government payer, and then you're talking another few percent for self-pay. And then about 30% is commercial insurance. And so if like, you're a fire chief and or you're a third service and you're getting a lot of heat from the mayor and you're looking at this small suburban town and you know that it's a town of 30,000 people and there's 1,200 people are going to turn 65 in the next year, you need to count that in your budget. You and the census need to be hanging out. If you could figure out, or at least rate, through clerk's office, hey, how many people am I going to lose? Because now my payer is going to go from 1,100 people are going to go from commercial payer to Medicare, right, on the day of their birthday. So those are the stupid things and silly things that you want to pay attention to, but it's really going to put you in a positive way to show your bosses, your chief executive officials, your senior VPs, whoever you're reporting to, that you've got these things figured out. And I think that that's really, really important, right? So when we look at the others, we already talked about the fee for service and the financial burdens, because they're nervous about. Sorry, I got sidetracked there. They get nervous about getting a bill. So now you get there. One of the challenges of fee for service, they got a bill the last time. There's not a copay. It's not covered. I just had a case come up at the hospital that I work at, and the case, the ambulance wasn't covered, and we sent them by ambulance from one campus to the other for a higher level of care. So now, of course, they're calling our patient relations trying to find an issue. So what happens the next time that patient or somebody related to that patient needs a higher level of care? The complexity of the fee-for-service models are going to be like, I don't want to go to the hospital by ambulance. I got charged for that. And I've had that happen in the 911 system too, when you're working in the field. So that is another problem, right? We certainly know that the payers, we're shifting more and more Medicaid and Medicare as the baby boomers all turn 65. We have an aging demographic. And so what does that mean? It means more work, right? More call volume for less reimbursement. And that is going to be hard for your employees. And so we need to brief that. We need to find a way to get ahead of that. And we go back to last week's lecture about leadership and management, the transparency, because they don't understand. It's like, when I say they don't understand, if we're not telling them, they're not going to understand. They're very smart. Our employees are wickedly smart, and we just have to be transparent. Like, yeah, I know you're doing 10 calls a shift and you used to do 6 calls a shift. I understand how burdensome it is to have a 1.02 call per hour kind of thing, and the UHU is starting to adversely affect your daily working condition. But let me explain to you why. Right, this is our payer mix, right? And so we have to do the quantity, we have to do the call volume. The issue is going to be the reimbursement. So if Medicaid's paying me half of what Blue Cross is paying me, that means I got to do 2 Medicaid calls for every 1 Blue Cross call, right? So that's another thing too when you look into business development. Where are you going to set up shop? Where are you going to look for, if you're going to expand into a market, where are you going to look for expansion into a market? And then you also have to look at, and this is where this fee for service model complicates overall healthcare with revenue, is what work can't I do? If Medicare is going to pay me $77,000 annually to do a dialysis trip, repetitive dialysis trip 3 times a day, and then they're going to audit the heck out of me every time I have my paperwork wrong and subject me to 7 years of records that I'm going to have to pay a fine on, do I even want to do that work? Is it even worth it? I mean, if you're running an ALS ambulance 3 times a week, you have 2 employees, so that's an annual salary, let's say median annual salary of $67,000, right? So you've got essentially you're getting paid $77,000, right? And you're spending, I don't know, 40,000 in labor, 20,000 in labor, and that's not counting, does the person get hurt coming down the stairs, the fuel, the vehicle, all that other stuff, and did you miss a 911 call or a SCT call from a private insurance doing it? So you're seeing a lot of these larger companies, and they're just stopping some of this work, and that proposes and presents a whole other slew of problems when we start now backing up these patients into the hospital, right? So the budgetary is, you want to be 2 steps ahead of it, absolutely, absolutely sure. And you want to understand that there's always going to be a discrepancy between what the cost is of the service versus what is the reimbursement rate. And our job is to try to reduce the cost and make it more efficient with the reimbursement rate. Is it all doom and gloom? No. I mean, look at some of the things. First of all, we have a lot of federal agencies that are on our side, right? I mean, we have Department of Homeland Security, we have NHTSA, we have Health and Human Services, Department of Defense. All of these things require some form of involvement with emergency medical services, right? And they're going to be feeling the same pinch we are. Like, look at the military bases and the way they do their fire suppression and EMS. They may be dealing with the same thing we're doing. They're also dealing with an issue with the Veterans Affairs, right? Because DOD manages Veterans Affairs. Many veterans are infirm and need ambulance transport. So if we don't have ambulances, they can't move their veterans around. So there's other lobbies that are obviously going to work to try to make this program sustainable. The other thing is technology. Dispatching ambulances all across the city with a pad and a pencil is gone now. Even our computer-aided dispatching that we were using 5 years ago is starting to become antiquated because we now have AI that is guessing where the next calls are going to be, or stacking the interfacility transfer. They're reducing UHU, but they're not making it overly burdensome on the employee. So it's really impressive. So if we start to look at maybe new, experimental or enhanced ways to do business, the efficiency is going to get better, the costs are going to go down, then we can stick around with the same level of revenue and reimbursement. So that's a quick overview of the learning objectives and the points that I kind of wanted to highlight. Make sure you guys are doing your reading and you're doing your assignments, looking for alternate resources, and thanks for listening.